we have two types of tubes, right? The Dubov tube will never be a gastric lavage tube because it's a feeding tube and it goes into the enteric part. So I'll leave that for another video. But for gastric lavage, we use a Levine tube, which is a tube with a more rigid structure. After all, it's a short-term tube, right? We insert it, leave it in for the shortest time possible, and then remove it, unlike the Dubov tube. So, what do we need to take into consideration? If this patient is actually going to undergo gastric lavage, what should we consider about this tube being a bit more rigid? Depending on how long the person has had it and the type, we might have some surprises. It's during the insertion, right? Okay, so the insertion can be a problem. I'm not talking about the esophageal passage. I'm talking about after the cardia and forward. That is, after it enters the stomach and beyond. Because maybe that's where some changes happen, anatomical changes there made by the surgery. So what do you do then? Is this the right place for gastric lavage? Will you perform it and how will it work? Another thing is that when we do a gastric lavage, we put in a certain amount of liquid and then we stop and we do the drainage, put in liquid drain, and so on. But now if we don't have a stomach with the same capacity, then what capacity are we going to use? This gastric lavage gets the point because depending on the situation, a lavage might not even be recommended. Because if the stomach is smaller and you infuse volume there to remove it later. But if I don't have, let's say, the capacity to store in the stomach because it was removed, modified, altered, this liquid is going to the enteric part, and what goes to the enteric part can't be removed through the stomach, right? So the lavage became something that wouldn't apply.